mainly with special districts, but also critical access hospitals, standalone EMS, and other nations. I was originally going to talk very, very granularly on revenue cycle, but after watching yesterday's presentations, I shifted a little bit and I'm going to do a little bit more of a holistic approach to finance, pairing in the revenue cycle with some gap funding solutions, as well as some other techniques to understand the full comprehensive side of finance for your different organizations. If you want to dive into a more of a topic, like I could go anywhere with this presentation, feel free to interrupt and we can dive into any of the core topics that I have today. To give you a little bit of backstory, so I started off actually on the clinical side. I was going to be a nurse, went to school for nursing, worked in the ED, loved all of it, and still just wasn't like turning my crank. Y'all know exactly what that means passion-wise. Something just was missing for me. I actually went back to school for accounting and finance, stayed in the healthcare sector, but I've moved my way through from the finance lens. And what's really nice about having the clinical experience as well as the finance experience is I can't like just go cut costs because I'm like, oh, how's that going to impact like the nursing team or the EMS team or the docs? And so we can have really great conversations because I've been on the floor. I've been there doing different things. I used to also do all of the EMS testing in Grand Junction. So I was like the dummy that you taped to the board. I've done it all to be able to support with the process. Recently, though, in the last 3 years, my company has pivoted and started helping failing facilities that are financially in like horrible hardship. Some of you have probably heard of the story of like St. Vincent General Hospital or Delta Health. We were in the paper all over. It was great stuff. But St. Vincent is probably one of my favorite stories because when I walked on site in September of 2022, we had -6 days cash on hand. I was calling our dear friend Kim Bimster at HICPOF begging for money every day. And then our good friends at RETAC got involved because the ambulance was tanking part of the hospital. And so we had to come up with a strategy to financially turn this hospital around or close its doors. But all of us know in emergency medicine, the golden hour is a legitimate thing. And if we were to close St. Vincent, which is located in Leadville, Colorado, which is, by the way, the highest hospital in the United States because it's the only hospital that's 10,000 feet, which creates its own problems. But it's over an hour and a half away during a snowy winter on a single line highway. You can imagine how much fun that is for an emergency bus, right? To get a patient to care. And so putting my heart and soul into these turnarounds, these hospital turnarounds, really kind of shaped how I approach looking at finance for any department. And a lot of them, like I said, that we work with our special districts. In Colorado, special districts have its own set of fines because of TABOR and the limitations that come with the TABOR regulations. And so I wanted to talk today about how I chose to go about evaluating the department itself, specifically in St. Vincent, how we worked with RETAC and completely went a completely different direction than what they originally thought we were going to do because we were talking about spinning off ambulance, going specifically with the county and all of those things, and how we've since made it successful. And then through that, I've added some additional concepts in here on how do you hold others accountable so the situation doesn't happen in your organization. We were talking about how do you measure your biller? Like how do you know if they're doing well or not? How do you measure your finance person that's doing their financial statements and are they accurate? Or how do you know what grants to go after? And like, do I fill the gap with a grant this year or do I fill the gap funding with something else? And so I'm going to try to use all the presentations that we've seen and kind of connect some dots a little bit with mine today. Again, I could take this wherever you want it to go, so feel free to interrupt me and we can talk about any topic in more depth. Let's see here, computers start to cooperate would be great. So the first thing is each one of you has some sort of leadership capacity or a higher level capacity in your organization. Knowing your numbers is really, really important. There was a question asked earlier about, well, if you're part of a district or you're part of something, how do you know your numbers to create the narrative for the grant application and whatnot? And what's really interesting to me is how many department leaders or executive directors or organizational leadership don't pulse on it in any way, shape, or form. And just because you're wrapped into other funding sources, like I'm right now helping a fire district in Montana, and like their bank accounts literally commingled with everything else in the county. And so you're trying to peel it apart and figure out what's their money versus not. It's still really important to have some sort of active pulse on it. And what's funny to me is I find that my EMS departments actually have a better pulse than most of the other departments in the hospital. It's really kind of fun because it's not something you normally would expect, but knowing what those things are is super critical. So a couple things that need to be known. First of all, accountants tend to make things complicated. In case y'all didn't know, we like to call things a bunch of words. And then when we get bored of those words, we change them and make it more confusing. Like income statement is also profit and loss, which is also statement of activities, which is also, I mean, I could keep going. Like we're really good at not keeping it simple, stupid, right? When it comes to looking at your guys' individual organizations, I don't care what you have to submit for like a state grant or an audit or whatever. If the data isn't understood by you guys as the leaders to use every day to make decisions, it's crap. And I just made some accountants roll over in their grave. But my point being is, when you get your reports, whether you're producing them or you're working with your accounting team to produce them, they need to be functional for you. So like if you were to talk to Jeremiah over at St. Vincent, because him and I talk all the time about his finance stuff, his reports are very different that I give him than the reports I give other department heads, because he wants certain data points every single day or month or quarterly that allow for him to drive decisions within his realm and his controllable realm inside the ambulance and EMS department. Just because GAP or GASB, all these fun acronyms that require governmental reporting standards, requires it to be displayed a certain way, that's for that, not necessarily for your guys' organization. So if you're looking at your profit and loss and you're like, these categories mean nothing to me because they don't give me indicators of what I really want to manage, AKA my staff, and the cost of all those shift differentials and all the crazy things that happen within that, or the cost of additional supplies, God forbid, maintenance on these ambulances. Most of them are phased, they're so old, we're trying to like piece them together to make them last longer, right? In the process. But if that data is not clearly spelled out and it's mixed into an accountant's line item of something else, how are you managing that? How are you aware of those individual specific details? So I think understanding your numbers is like point one, part one. Part two, you need to understand the cash flow of your department. So I don't have a whiteboard because I'm a really visual person. So visualize with me. If you have a scrap piece of paper and you want to keep up, you can use that too. But like revenue cycle, isn't it like the stupidest, most confusing thing ever? No? Y'all can laugh a little bit. Like this is energy is good, right? We're the only industry that has a menu of prices that doesn't get paid the menu.
Yep.
No?
Oh, yeah.
Oh, yeah, that's okay, so it's confusing. It has no direct translation to cash whatsoever, but yet we're expected to miraculously have cash in the bank to pay for all those shifts, to pay for all of the needs we have to have, right? And so just because a profit and loss is like, well, your gross charges minus your allowance minus your reserve gives you your net. Great. Do I have money in the bank to spend or not for my department? Right? And so personally, I think every single department should also understand its actual cash flow. How much money are you actually getting per transport, per type of transport, for each level of acuity? And then is that cash high enough to even cover the expenses? I'm gonna show you a really fun exercise I do to kind of peel this apart. Y'all are gonna go back to your accountants and like freak them out is what's gonna end up happening. Yes, sir.
I'm sorry, I have to pause just a second.
That's right.
Jim, are you okay? Me?
Okay,
That's fine.
I'm watching.
That's the one. It's the one. Yes.
Okay. But again, to me, I'm like, we've made it so freaking arbitrary that, and then we're expected to miraculously figure out how to manage it. Which is why I'm like, cash flow, cash is king, right? And so when I think of St. Vincent, like our ambulance, when I first started analyzing it, was losing like $750,000 a year after tax dollars, right? And when I have a hospital with negative 6 days on cash, you can bet as CFO, I'm like, which departments can I cut? That's why RETAC came on site. Well, then I started analyzing the cash flow with Jeremiah. We started looking at shifts. We started looking at utilization of his staff and how to make sure we don't have to cut staff because we need them, right? But we found out a really cool process of doing that. I'm going to show you some tips and tricks around that here in just a second, to where the ambulance now is profitable with the tax dollars like on top of that. And so there is a way to shift the mentality around it. You literally have to go and blow up like the financial books that we keep for the sake of formal records and get down to the brass tacks numbers that actually matter to your guys' departments. And that includes things like statistics. How many transports are you doing? Did it go up or down this month? Do you have volatility? Is it seasonal? How does that impact your organization? Like I track all of those things and I pair it to cash in the bank and I'm like, volumes went up, but cash went down. Why? We saw less payer with less of this payer, more of this payer. We got paid less. Interesting. So, I mean, I know we can't control our payer mix in emergency medicine because you're like, no, sorry, you're Medicare, can't touch you. That's not how that works. But at the same time, if you have an awareness around it, you can kind of structure and strategize around your department on like, okay, if we know we have an increased Medicaid, Medicare population, is there alternatives? Are we going to cover the gap with grants at this point? Or are we going to cover the gap through maybe cost-based reimbursement? There is a way to do that. So we're going to talk about some of those more here in just a second. All of this then pairs with how you're structured. So there was a question earlier about nonprofit versus governmental. Those are fun. Colorado, by the way, I thought Oregon was going to be worse because I have a hospital in Oregon now with an ambulance. Colorado still takes the cake with special district law. Oregon's easier. She couldn't quite say those words. But here we are. So the entity type that you're in will also dictate how you go about tracking your numbers too, right? So let's talk about that and unpack those layers for a second. If you are standalone and you are a nonprofit, what kind of alternative funding sources do you maybe have available to you that a governmental entity doesn't? Does anybody know? I'm gonna look at one person in particular.
You get other kinds of grants.
Yes, you can. Yes, as a nonprofit, you can actually get charitable donations from individuals they can actually write it off as on their tax return because it's a 501c3. That is the taxable donation. Governmental, they don't get the donation the same, by the way. You can also get additional grant funding alternatives through foundations and whatnot. What else is unique about a nonprofit comparative to governmental? Where was the short circuiting? Anything else? Anybody else? So from the nonprofit side of the coin, not only do you have grant opportunities, you have charitable deduction opportunities, but there are some additional programs that you can actually register for at both the state and federal level that again give you additional reimbursement. It just depends. Are you a standalone nonprofit or are you affiliated with like a hospital or a different system, right? Let's unpack governmental for a second. What are some of the restrictions on governmental? Huh?
Law, paper.
Tabor. What's Tabor, by the way? We think it's dumb, right? Like we're like everybody like Tabor, taxpayer bill rounds. It sounds good, right? But why is it dumb? Why do we have that response?
Because you give back like $10 when that $10 made a big difference to the agency that it came from. It doesn't really make a big difference to me to give back a couple of dollars.
Okay, so that's at the individual level. But let's think about it from a governmental lens. If you're the special district, why does Tabor matter? Yes, sir.
So there are parts of Tabor that you can exempt yourself from,
Okay,
and there are parts that you can't.
correct.
So for example, you can de-Tabor your revenue, and your spending limits. But you can't de-Tabor you just can't raise taxes without a vote for the people.
Correct.
And, but the big thing is once again, and even like when we redid Gallagher, you can be Gallagher, theoretically, well, we did be Gallagher, but now you also have to with some of the revenue limits with the activities that the state is doing in readjusting the RAR and the assessment rates, you can go back and ask to at least keep the revenue from at a certain spot.
So in other words, you really loved their special session that they had last year that caused everything to delay till January, is what you're telling me?
Yes.
Yeah, I just loved it, right? No, so why I'm bringing up Tabor and why it really matters for everybody in here, and for those of you that don't know, I'm gonna give a little overview. Tabor has obviously some limitations. You can go and ask for certain concessions to it, for lack of better words. However, with Tabor, you're not allowed to take on debt that's longer than 12 months. You're not allowed to take on contracts longer than 12 months. You're not allowed to, if you do go for financing, you have to go to your voters. It has to be on a ballot initiative. So you have to pay for a campaign to get them to be aware of what the heck you're asking for, right? And then on top of that, if you're going for like mills or mill levies, God forbid you fill out that DLG 70 form wrong and you round the pennies up instead of down, you're now in Tabor violation and you can get in trouble when it comes to that certification. In addition to that, you have to really watch abatements in your county and how your county handles those abatements for property tax or sales tax, because that can impact your tax dollars and how it flows to you. You can see all these limitations and how Tabor functions. And so when you have that restriction on there, you have to get really creative because most vendors don't want a less than a 1-year contract. Most debt is not under a year. Most, you know what I'm saying? Like there's so many things you have to consider. So when you're doing your financial planning and you know what your cash flow is, and you look at your numbers and you know what your goals are, you have to then think that much further ahead for future planning if you do need to go ask for a Tabor exemption or go to your population and voters, or you might even need to look at redistricting or the structure around where your county lines are. We're actually doing that for one of our organizations because the county is on a different district than the hospital district affiliated with an ambulance. We're going to ask to match, which changes our mills, which changes our reimbursement. But again, that's a strategy. You have to look at that far in advance. You had your hand up.
In every contract that exceeds 1 year.
Correct.
Have to have it.
Correct. Yes. So the point is, you have to, if you're a special district, Tabor alone does this. It puts ties your hands behind your back, and you have to figure out how to do your job, right? Layer on top of that with a special district, you have open records acts, public board meetings. On top of that, you might have some grant limitations because governments usually can't get grants, which is why you have to strategically, when I get to the grant section, because I'm going to partner with your grant conversation here. Well, some strategic alliances are super important to flow some money to your organizations as well. Because if not, as a special district, you're kind of hampered. Then you have the third type, which I say it's a third type. Technically, it's going to be one of those two, usually. But the third type is that's tied to a hospital. So how many in here are actually tied or affiliated with a hospital system? So none of you guys? All are standalones? Score. So you don't have to worry about that red tape. But if you're tied into a hospital system, you're dictated by the hospital's overarching budget, hospital administration, and those types of initiatives as well. So if you're standalone, you have a little bit more autonomy. You as the director get to choose those goals and initiatives. But if you're not and you're tied into a hospital system, you're at the beck and call of what their missions are. Yes.
True, that even though you're nonprofit, you're financial for profit because of the tax exempt.
It is. You could go on GuideStar and look up any 501c3's 990 filings every year. It's public knowledge. IRS is required to publicly post it, as well as the Colorado Secretary of State requires charitable organizations to report that all online. So it is public, but it's not the same as like the TORA requests for a special district. But great question. And then, of course, you have some for-profit transportation companies, which those are completely, the incentives are completely different. Obviously, you could choose whether or not you want to play within certain aspects, if you want to play in the payer space or not. But then you have to remember, if you are the nonprofit or you're the special district, you might be competing against some of these companies. And so how does that look in terms of your area or your region? So again, understanding your numbers is going to be dictated by how you're structured, right? So think of St. Vincent and the fun debacle we went through, like I said, with the RETAC team and that ambulance. we really didn't want the ambulance separated from the hospital. I needed my paramedics in that emergency room more frequently than we realized, right? Crossover is astounding. And so by losing ambulance, even if it went out on its own, the contractual relationship would drastically change. And so our nursing staff would have been understaffed in terms of inpatient swing and ED, but also our community would have not had the same relationship, right? The other piece to all of this is if you wanted to change your reimbursement model. Anybody in here cost-based reimbursed at all?
Well, actually, only,
Elaborate.
a lot of us are in the public agency supplemental
Okay,
reimbursement program, so that's not like critical access hospital cost-based reimbursement, but it's a portion of the cost-based reimbursement.
correct,
Mhm.
right? So you can get some incentive payments, and you can also do that through Medicaid, right? When you can file a Medicaid cost report and get some additional incentive payments from Medicaid for that population. But also if you're more than 35 miles away and you're the only ambulance district in your area, you can actually apply for an exemption to be cost-based reimbursed ambulance, which is just like a critical access hospital. Our critical access hospital for St. Vincent, we just actually did this as part of the RETAC strategy. We created and did that application process. We were 34.7 miles.
I know
Which
a
is
way
under-
around that.
We did.
Yeah, our hospital found the way around it too.
We did. We got an approval. We went through CMS and got the exemption approved. And now our ambulance is cost-based reimbursed. For those of you that don't know what that means, I fill out this beautiful cost report and show all the costs affiliated with ambulance, and I get paid $1 and a penny now on cost for my Medicare transports. Medicare is no longer that painful thorn in my side because at least I'm breaking even. Now, break even's always broke in my brain, but it's better than what we all know Medicare can reimburse otherwise, right? And so having that strategy is also really, really helpful in terms of your entity structuring. So again, I challenge you, if you don't know, go back and research how you're pulling your numbers. Are they useful to you? And what your entity structure is, and really understand that. Those are the first three. I was actually sharing just a few minutes ago. 9 times out of 10, every failing hospital that I walk into is due to lack of administration's education or understanding of the model they're in. I look at St. Vincent's original leadership, which I'm limited to what I'm allowed to say. But prior leadership did not understand cost-based reimbursement. They did not understand how critical access hospitals were reimbursed. Delta Hospital, same thing. Their sole community provider, PPS Hospital, leadership did not understand how that reimbursement model worked. And so they spent money incorrectly in the wrong departments, in the wrong sections. I have a fire district right now, pulling them out of the weeds. Prior executive director did not understand special district rules, was running it like a for-profit entity, kind of killed it and to cut it off at its knees. So understanding your entity structure is mission 1. This will then roll into how you bill, how you function, and all of those other things. I'm going to pause for just a second because we're only on slide 1. Any questions?
Advil uses their trick to escape the 35-mile rule.
We actually applied for an exemption through CMS, yes.
Yeah, our the Gunnison Hospital actually
Yes.
created a regulatory structure to make themselves the exclusive provider in that area. That was like a regulatory.
Yeah, and we were already exclusive providers, so we were able to utilize that status.
Nice.
But yes.
Yeah, so Kim did all the initial legwork in Kit Carson County that never went anywhere that they ripped off and $1 million out of.
Well, Gunnison, your CFO and I talk often, so there you go. And again, all of this does matter because even though I know you guys don't necessarily hear about population management in terms of continuum of care, like all of the other sectors of healthcare do, you all are part of that narrative, by the way. I mean, when I'm talking about my federally qualified health centers, my RHCs, and I'm talking about a specific population to be able to prove that I want a better reimbursement rate for primary care, you bet your bottom dollar I'm bringing EMS stats right into it. How many players am I busing elsewhere? How many players am I, why are we getting call outs? Are the call outs being like, is it not appropriate? Are we transferring patients to acuity to another facility because we can't handle it. EMS plays a huge role in population health, and I have a hunch, pretty good one. Federally speaking, there's going to be some new changes coming down the pike around EMS and reimbursement rates. Good friend of mine may or may not be Senator Joe Manchin's policy advisor, and so we work together on a lot of projects. So let's talk about current landscape. So I'm going to play off of Asbel. Did I say it right? Asbel's presentation yesterday. I love insurance companies, don't you all?
Try to figure out.
Some days I wonder. Anyway, you want to know what's really sad? Okay, so I'm going to nerd out with just for a second because I feel like I'm in a safe space to be able to nerd out on this stuff. If you study the historical model of insurance, you think about this. When you think of why Social Security and Medicare was even started back in the 60s, 70s, the concepts and what it was meant to do, our insurance companies have definitely skewed that model pretty rigorously. However, they do it because they can get away with it. I loved his comments yesterday about, 8 out of 10 appeals will actually result in a positive thing for your organization. Because you know how many people fight the insurance companies? You know how many they anticipate fighting them? Right? Like I hang out with Patrick Gordon all the time from United Health because him and I'm going to pick United all the time. And so I'm always telling him, like, hey, you're not paying. He's like, you're the only one that is so freaking squeaky. Like, I have no choice but to pay you because you're annoying. Yes. Like how it should be. And I understand. And I understand y'all are like, you're like, I'm a small organization. There's 2 billers in my office or 1 on a good day. How am I supposed to be the squeaky wheel? I don't care if you have to create an Outlook automated email that sends every week reminding them to do those puppies, do it. Because I'm going to tell you, the more and more people start holding these payers accountable, the game will have to change. I can tell you right now, your legislators, especially at the federal level, are being sold a completely different narrative than the narrative I know to be true. I got this opportunity, just finished my master's in healthcare delivery from Dartmouth, and we got the opportunity to work with the federal regulators on some initiatives, right? And when I was talking with 2 of the senators, they were like, yeah, these advantage plans are selling to me like all these amazing things about what they're doing for patients and stuff. And I'm like, yes, and they're going to kill every rural hospital and district that I know. And they're like, wait, what? Because they're being sold the complete opposite narrative. So if we don't speak up, they're going to keep doing this. Okay, sure, I'll sign and make sure Medicare Advantage is going to be on the docket. Like they're totally bought into it because they're the only ones talking about it. So in other words, be a squeaky wheel. That's part 1. Yes, ma'am.
Be a squeaky wheel when we hear from the different insurance companies that we don't really want to talk to you, we want to talk to the patients. So we tell the patients what they need to hear, but there's a lot of times they won't speak with us to be the squeaky wheel.
I'd be saying, who's your boss? Because I'm going to tell you right now, if they want to start talking to my patient in the conversation, I want your next level. Our patients don't know half the insurance plans they bought.
That's the whole thing. We tell them what to say. 50% of the time it works, 50% of the time it doesn't work. And I'll say I will advocate for you. I can't guarantee, but I will advocate for you. And sometimes it works, sometimes it doesn't.
And I agree with you. And there's certain scenarios. I want to be very careful when I say blanket statements because some of y'all are going to go back and do something and be like, the lady said. That's not what I'm trying to do. But the whole point is like it shouldn't be the patient's response. If you're the biller and you're billing, you should be able to solve that problem. Right? Now we have payers that are paying direct to patient, and that's a whole other game we're having to play with a little bit more. But that's a re-education opportunity with those payers and those patients when you do transports or have those conversations. But in your particular case, I'd be pushing for the next level. And if you can't get to the next level, there's this cool organization that you're a part of that might be able to get you some resources to get you higher up faster. That's why I love associations. Like I used to not put a lot of weight into hospital associations or organizations. Don't take that the wrong way, sir. But the whole point being is like that's why you're here. They're here. They exist to create enough humans to show the population to fight for what you're after. Yes, sir.
So I just wanted to make something really clear, get back from you. Because my old billing company used to be a pain in the butt regarding appeals. My new company happens to be in the rooms. When it comes to appeals, our old company would always tell us that each insurance company has its own appeal process, its own form. You have to send that out, get that signed, you have to get the patient's participation in that. You're saying it's not true?
Not always, no. I would push back on that billing company quite a bit, actually. I love billers right now. Sorry for the billers in the room. Like, you're hitting me, don't throw daggers, I can feel it. But my point is, some of those appeals don't have to have patient, participation. Correct. Some of them, if you do need to get them involved, that's only literally a short period of communication between you and the patient, not the patient and that particular insurance company. You are the intermediary, you're the biller, you're the billing company, you're the one trying to get paid, not the patient. The patient's gonna yell at you because they don't want patient responsibility. But you're gonna be the one defending it. I have so many billers that I have terminated or restructured billing departments over due to their lack of want and or grit towards appealing or pushing back. Yeah. I mean, I hate to say this, again, I'm probably gonna get daggers thrown at me, but I'm a very blunt and transparent person. If the whole point of a biller, it used to not be this way. I want to be very clear about what's going to come out of my mouth, but you've turned into a block and tackler. You're no longer just putting CPT codes, ICD-10 codes, and modifiers and shoving claims out the door. Those days are long gone. I mean, AI is going to take over that part of it here soon. Let's be real. Your job as a biller is block and tackling those freaking insurance companies every freaking day on the back end after any billed claim that hasn't been paid. Your responsibility is to follow up and follow through as a biller. And if that billed unpaid report does not get less, if you want to talk about how to hold your biller accountable, that unpaid but billed hasn't shrunk, they're not doing their job. They're lazy. I know. We just said the lazy word. And none of y'all are in this room, right? It's fine. And now I'm speaking to really good go-getters who would be here. My point is, though, they need to be pushed back. I have a revenue cycle director I just fired over not wanting to do appeals. But anyway, I won't tolerate it. Like, your job is to help make me money. You're one of my most important players on this entire team. My EMTs can only see so many patients for free. Anyway, okay.
Are you in the insurance company negotiating space as well?
I'm sorry.
Are you in the space where you negotiate?
I only negotiate for my actual clients. I don't personally just do it for fun. I mean, I do it
How
because
do you do it?
I will, but oh hell yeah, I'll go to the mat all day long. But the thing is, I have to have good data to go to the mats. Going back to my first slide, if I don't have good if I don't have good stats, y'all aren't writing down your transports. It's really hard for me to go yell at Blue Cross or United if I don't have your data. So coming back full circle to why us CFOs are that annoying person that asks you all the time for your reports, or the lovely Medicare ground ambulance reporting requirements now that you have to ask all these additional questions. If you're not tracking those statistics, I can't go to the map. Yeah.
Well, I think the basis of my question, I should give you a little more context there. But I mean, I think what we know, and when we're talking about balanced billing and locally set rate conversations and those kind of things, the only people in the state who appear to be negotiating with insurance companies on ambulance rates are really the hospital-based systems.
Right.
And that's an efficiency play because they're doing that anyway. And a lot of the rest of us simply are not, because there's no value.
The table with the hospital that you're helping bring patients to.
Yeah, no. More comments on that.
I'm really fired up, so I can't talk.
Yeah. We're thinking going down that route. And it seems like the answer is probably for the network if I can't control my administrative efficiency out of it.
I would beg to differ a little bit. I would do some additional analysis in terms of what your current mix is and what your patients in your area are served by. And then if your hospital's already at the table negotiating those contracts, sit at the table with them and say, I'm another service provider in this area. I'm not getting paid by you all. I'm taking patients and driving them to this hospital. Why can't you pay me a better rate? I just did this for a hospital or a district in Montana. Their hospital was renegotiating a rate with Blue Cross. Blue Cross was playing the ambulance. Let me just be real. Percent of charges. I want to puke. Should be 85. Just throwing that out there. And so I told the ambulance district, let's come to the table. Let's be a united front. Let's leverage. It was really interesting. Then they backed off and they gave them their contract as well. So again, it doesn't always play that way. But to me, again, insurance companies just they expect you to just say it's not worth it. They really do. So I would challenge your thought just a little bit and to run some numbers on it to see if it is worth it. But if you already have a player in your community that's already going to bat for those contracts, why not ride the coattail? Just a thought. Insurance reimbursements. Right now they're making us all play banker. It's one of my favorite, right? Like an ultimate lending agency. I know Medicare is supposed to pay 14.21 on a lag. Medicaid, same thing. But the problem is it's getting more and more difficult to have that be the case anymore. Also part of that though is clean claim rates. They're dropping. Again, going back to my earlier lazy comment that I got the ooh over here from. There's a truth, like the clean claim rate, the first pass denial rate is not gone down on average for any organization I serve. That taking the patient demographic and checking that patient in, whether it's, I know it's not easy in your guys' specific niche of the healthcare sector, but if you don't capture that front end well, your clean claim rates are going to suck. And then you get to play banker for 60 to 90 days while you're trying to fix it. You're floating those costs and now paying somebody to fix what you could have prevented by just spelling a person's name right from the get-go. Yes, sir.
So back to the critical access ambulance.
Uh-huh.
Is it required in what you're talking about with going and talking with the hospital? Our relationship with our critical access hospital, that's okay. So is that a mandatory thing that we would have to go to that, or can we seek out the critical access ambulance in that patient without it?
Oh yeah, you could totally seek without. You just have to watch. If I'm understanding your question correctly, but you don't necessarily have to, I guess, leverage that one particular relationship. You can leverage others. Is that what you're asking?
I guess I'm asking if we can go out on our own and do the critical access.
You're talking about cost-based reimbursement.
Yeah.
That is a loaded question. I'm gonna have to research that one and get back to you. It's a good question. Don't let me forget it though, before when I'm done, I can it's
My understanding is to build critical access for ambulance, you have to be part of the critical access hospital.
but he's not billing critical access, he's billing cost-based.
With what?
He's billing cost-based, not critical access.
I know, but to get cost base plus 1%,
Yeah,
the only way right now, how well I can do that is if you're affiliated with a critical access hospital.
Yeah.
NAEMT is looking at getting legislation, putting a bill to be able to establish the critical access ambulance designation.
You are correct. Yes, what he just said. And that is where, like I said, Senator Joe Manchin actually just released a bill on this, specifically at the federal level. It got a lot of pushback from the fire districts. I don't understand why actually the fire districts. It's actually really shocking because I'm like, this is gonna help you. But anyway, there is at the federal level for what he's talking about. But there's some other ways to get some additional reimbursement, cost-based driven as a standalone. That's not cost-based in the sense of critical access billing, the 101% that I'm talking about earlier. Obviously inaccurately paying out claims. So one of the other things that was asked yesterday in the billing conversation was, well, how do you know if you're getting paid appropriately or not? So if you don't have contracts, so I'll go back to your comment. If you don't have contracts, you have no leverage for accountability around payments other than your fee schedule, right? And so, and even then, they're paying usually a percentage of Medicare or their percentage of charges, and they're going to arbitrarily come up with this number.
oh, they do.
Oh, yes. Even though they're supposed to honor your fee schedule, I don't have a single case where they usually do that 100%. Let's just be real. And so really understanding how you guys are sending out claims, if you do have a contractual relationship and if they are paying according to contract, is super, super important. There's lots of really cool software plugins. I know you guys are all probably in a different software platform, but there are ways to actually have that preloaded and do an analysis on the back end. To be able to see whether or not claims are actually paid according to your fee schedule or agreement. But let's just be more realistic and simple. Do a spot check audit for every payer, a handful every single month, and have your billing company do that analysis. It's really, really critical. You'd be surprised how many people get not paid according to their original agreements or their fee schedule. And we're not talking big dollar differences, okay? But when you think about it and you think about $20 per every time and you multiply that by however many transports you've got going on, it's a lot of freaking money. Right? And so the accountability of our accurately paying claims is actually super important. Again, they're banking on you guys not saying anything because we're the small guys. We don't have the multiple back office support like a UHC or an Intermountain does. I mean, they're banking on the little guys just letting it slide. So having that again, going back to the accountability around your payers, super, super important. The whole revenue cycle process, I'm going to go through a slide. It's built originally for a hospital, but it's still, in my opinion, so eye-opening of how many pieces could go wrong in a revenue cycle. To me, poor systems management is usually where a lot of the revenue cycle issues come to play. You should be tracking your denial rates. You should be tracking how many claims go out the door per day comparative to the volumes that you see per day. You should also be tracking the first pass denials and clean claims rate. You should be tracking line item denials. Which lines don't pay consistently every single time? And why? Why? Why put it on there? Is it a document deficiency? My favorite, my coding companies, if I require a coder, if I outsource coding, I require a daily document deficiency report to tell me when they had to upcode or reduce the codes based off the documentation by each individual provider. That is a metric. Thank you. Because if you have that metric in play, then you know whether or not you are documenting accordingly. I think there was a question yesterday about, well, I'm afraid if I'm going to overbill. Well, your documentation should be analyzed very consistently. Not daily, it should be weekly from your coding team. If you again, a lot of people outsource coding because of the specialty and all the requirements. Require them to provide you with that reporting. I use HCCS a lot. I'm gonna pick on a vendor just for fun, why not? I require every day they send me a report, document deficiency. I provide. It's okay to demand it. They won't charge you extra. It's their job. Okay, super, super important. Obviously, that we know a whole bunch of new fee schedules and the proposed changes. Yesterday's presentations 100% cover that. And then, of course, we know workforce retention is a huge part, especially in your guys' space. Finding individuals that want to cover the shifts, cover the right shifts. I'm going to make a fun of generations for a second. These newer generations just don't have the same freaking work ethic as some of the other ones, right? I'm going to totally hit on somebody. I'm sorry. But like it just kills me because they like, well, I only want to work Tuesday, Wednesday, Thursday day shift. Cute, right? But the thing is, we need to figure out what our staffing costs are. Is there another way to offset those staffing costs? So going back to grants, I'm going to talk about grants a little bit more here in a second. I'm probably going to run out of time. You just kick me off whenever I'm done. But from a grant lens, like make sure the grant supporting a program you're already doing. Don't have to like reinvent something in order to get a grant. I hate that unless it's something you really want to achieve or do. But like when it comes to staffing, you have to figure out what motivates them and then figure out how do you pay for that particular motivation. The newer generation, they don't care about pay. They want time off. Do you have to change your PTO policies? Maybe. Right? So it just depends on generational. And then, of course, obviously, leadership changes. Leadership changes are actually one of the biggest reasons why most of the districts I work with are in some sort of mess. We have 17 hospitals in Colorado with no CFO. That's pretty alarming in my brain. And CEO turnover rate is at 38% on average right now. And that's just in the hospital sector. I can imagine if you break it down granularly to every division of healthcare. And so having some sort of succession planning for those that are more seasoned in your career of like who's going to actually take over your role, super, super critical from a finance lens as well. Because what happens is a lot of really great clinicians get promoted into leadership or great EMTs or paramedics, and then they're not armed, nor were they ever mentored because their mentor retired all of a sudden to know what their role now is. So if you have somebody that's a great second, mentor them on this stuff. So that way, when you do want to retire, God forbid, take a vacation, they actually know what's going on in the organization as well. Any questions on this particular one? Okay. So return on investment. I normally do an exercise, but I'm going to run out of time, so I'm not going to do it. But I would challenge each of you guys to think a little Dave Ramsey-esque with me for a second. Y'all following my drift? If you don't know who Dave Ramsey is, he likes envelopes. He likes to move money around. Anyway, point being is I want you to think about your departments and make sure every dollar you spend, that dollar actually has a job. And there's a solid return on investment for it. And one of the things that's really fun as CFO lens is that oftentimes when we're preparing the budget, we look at prior year behavior. And if you get really efficient, most of the time, those that are efficient are usually penalized because then they're now asked to be that efficient the next year. Yes. However, if you do know your return on investment from an efficiency lens for your individual department or your organization as a whole, you can make a hell of a case for the efficiency that you created to utilize those efficiency dollars for next year's projects. But you have to know your numbers. You have to know where the money went. So for example, if I know I was supposed to come in at break even or come in at 3%, and I came in at a 10% profit margin, that 7% difference because I cut costs and I made more money, I want to make the argument that that 7% gets invested into another project and or mission and or initiative for my particular company or my organization, right? So we did this with St. Vincent's Ambulance because they were such a loss leader for such a long period of time, completely swung the other direction. We had to make the case from a grant lens. I sat for some of you actually making a case as to why I wanted a new ambulance funded, right? And so now we're using the profitability components of that particular organization, like of that particular department, to fund the match. And then once that match is met, the new profitability is going to be funding, the build out of the ambulance barn. Because God forbid I didn't know that a Ford and a Dodge ambulance chassis, very different in measurements, and now my ambulance barn doesn't fit the way our ambulance used to be parked, right? But instead of penalizing for the efficiency, we're using that profitability that was generated in the prior year to kick it forward into a new initiative for the organization. So I want you to really think about every dollar having a job. The other piece is encourage your teams to get involved on this. So if you have multiple team members, multiple crews and whatnot, do a little bit of education on how they impact finance. What's really cool to watch is, like I said, those that are my organizations that have been financially failing, because everybody can rally around a good dumpster fire, right? When everybody's rallying around a burning platform, they start to understand their impact on the bottom line. But why aren't we doing that when we're not on fire? Can you tell your crews, like, hey, by the way, if we're really effective or efficient with this, or if you document this way, or if you help your patients this way, or if we, fuel up at this particular vendor instead of this vendor, you actually help our department or organization more financially healthy. That equals more pay to you later. If they understand what's in it for them and how they relate, 9 times out of 10, they're like behind it, 100%, right? Especially when your CFO tells you your department's going to be cut, right? Like they were rallying at St. Vincent because everybody was like, well, what do I need to do? How do we need to restructure crews? All of those different things. So it really matters. The responsibility goes down to the boots on the ground level. It's super, super, super important. The other thing is, we want to obviously continue to look at the productivity and the utilization. So staffing is always fun in emergency medicine because you have to staff, but sometimes they might be sitting there because the call outs haven't happened or whatnot. Is there another way or a more better, different way to utilize that downtime without compromising emergency care? Right? So if you are affiliated with a hospital system, you can utilize that. You can jump into the hospital space and support with that. If you're not, is there other things you can do in your community to get an additional return on investment? Going back to grants and leveraging grant funding, if you consistently are showing up with your community because you have some downtime and you're doing XYZ to help them out, whether that's helping out the fire district or helping out something else to that nature, oftentimes you can leverage those relationships later through a larger grant that maybe you're not eligible for due to your organizational type, but the money can flow through to some sort of initiative that you're helping them with anyway. Right? So money can come from alternative sources. I see this happen a lot. Like the 911 messaging call systems, helping with some additional education, stop the bleed initiatives, all of these different things. If you partner with other community members on these things, you can actually get additional funding sources for your organization, filling the gap financially for the downtime. So then you're no longer like, crap, how do I cover this crew's costs? Right? It's an alternative way of thinking about it. So I always like to think about gaps in terms of finance in 7 different ways. So when you're looking at your financial statements, your profit and loss or your cash flow, oftentimes, like I said, in the emergency sector, we find ourselves short, right? And so there's 7 different ways I look at it: capital, billing, financial data, changes in regs, staffing, patient care, and grants to fill for those gaps. And if you hit each of those dominoes, oftentimes you're going to come out in a surplus, right? But a lot of people instantly go to the scarcity brain and they're like, crap, I need a grant. Well, just so you know, grants have changed drastically and they go away just as fast as they come. And so a lot of people were building these programs based off of these COVID grant dollars. Well, guess what? They're gone now. And so now we're having to backfill for all of this money that was supposedly funding these things. Well, you can't cut crews, you can't cut different things for that. And so I like to look at each of these aspects individually. Again, managing patient reimbursement. I put contracts on here. He's not even here to pick on anymore. Contracts is super, super important. I think it's worth looking at. I think it's worth looking at alternative payment models and how you help your affiliated organizations. If you're doing transport between facilities for them, there's plenty of room for negotiation. But a lot of people are not going to the table to negotiate. Grants, as we already had a great lesson on grants, so I'm not going to go too more in depth, other than the fact, like I said, be very, very intentional. And then on the back end, make sure you keep the documentation for all the reporting. Because oftentimes what will happen is if you don't report correctly, you have to pay the money back. And that's not fun. Capital improvements. So when I say capital improvements, this might be building improvements, this might be new buses, this might mean equipment of some sort. You really need to do a return on investment or an analysis before you make this type of investment, right? So before you go and make a case before the Colorado board for a grant on a new ambulance, you have to know the return on investment for the investment in a new ambulance. Do you know if your old ambulance is truly at end of life? What does the repair and maintenance program look like for that? What does the service contracts look like for these pieces of equipment? Oftentimes, when I'm working with department leaders or executive directors in these organizations, they don't know this stuff, right? And before you go and make those cases for any capital purchase, you need to know, is it P, making me profit, or going to make me revenue? Is it going to be a revenue producing investment? Is it an R, meaning replacing something else? Is it an alternative? Is it a lower cost alternative? Or is it an alternative that's going to get me more efficiency or productivity? Or is it a complete and utter U and it's unnecessary, but I just want it? I see that all the time. Just throw that out there, okay? And so it's really important to analyze and look at that. And then from there, we need to figure out, are we buying it or are we leasing it? Because sometimes leasing it, depending on your entity structure, can give you actually a better financial outcome. You don't always have to buy. Sometimes buying gives you a heck of a lot better outcome. But a lot of people are not doing that analysis. It's kind of like, do I rent or do I buy a house, right? You're doing the same thing for your business. But a lot of people are not looking at their organizations from that lens. And then from there, how are you going to finance it? Is it age cash? Do you have enough cash flow sitting in the bank? Is it financing? Are you going to go through grants? Like, what is the funding mechanism for that? And when I say age cash, by the way, I really don't want people spending the cash that they made in the last 30 to 45 days minimum. You should be spending cash you made 90 days of that. Age cash, you should have 90 days cash on hand. You should be able to function for 90 days without earning another dollar before you have to completely cut your doors. Most people don't think that way, but building up that cash reserve is really, really critical, especially now because we're in such an interesting environment, both politically as well as organizationally right now, that if you don't have that cash on hand and you're spending current money, you're always behind the 8 ball. All right? Questions so far? All right, medical billing. We've talked a lot about this. I personally, I know this sounds funny. I know in EMS, you can't control volumes. And you should know what your break-even number is. Your ideal patient volume number is. You should know what your break-even number is. With how many patients or transports or what your mix has to be. Because if you are the director and if you're in the middle of the month and you know your break-even point is 120 transports and you're at 60, you're going to be like, oh crap, this month sucks. How am I going to make payroll next month? So we know it's always a lag, right? Billing lag, that 30, 60-day runway. This is that getting ahead of the cash flow game. If we're not paying attention to volumes and what our ideal volumes are, and I know it's kind of morbid to say from an emergency medicine perspective, but if we don't know what our ideal volumes are, and we're not monitoring day to day to that ideal, you're gonna, when the oopsie comes up to play 30, 60 days later, you have no time to react. But if you know I've had no transports, so 60 days from now it's gonna suck because I'm not gonna have payment in the door and I'm gonna still have to cover payroll. You now have 60 days runway to come up with a solution instead of waiting until the 60th day. So many people are thinking reactionary on this particular thing, and it kills me. This also means from a billing perspective, again, you need to know what your days not final billed are, how much is still standing there that's not been billed, what your denial rates are, how much has been billed and not paid, right? And how much of your aging is under 30 and then over 120. Now you can play games with billing. I heard a lot about it yesterday in your guys' the revenue conversation, and even the questions y'all had asked about, like what about the deductible and timing of billing for that? By all means, you can do those things, but you should still know where your aging is, because obviously the longer it goes out there, the less likely it is to left. Certain commercial payers, it's out of timely. You're not going to get paid for it, right? You're better off doing really cool programs like an early out initiative for your self-pay patients and saying, give me $20 a month instead of nothing, because $20 is still better than nothing. And you're also incentivizing a behavior pattern that you want to have happen instead of people taking a free ride and never paying you ever again. Right? So really, really thinking about that piece. And then of course, understanding your payer mix. Understand your community and who you're working within, because that also dictates how you're going to go about negotiations and those types of conversations. I'm going to real quickly give you some vocabulary because I think it's really important, and then I'm going to be that, right? 15? Okay, cool. I'm like, I still like halfway through the day.
Presentation has more value than mine, so I will concede my time. Ask questions and try to dig deeper. This is more valuable than mine.
Well, I appreciate that, and we'll work through this pretty quickly. I do want to talk a little bit about some terminology because again, accountants make things complicated. So when you're looking at your profit and loss, you've got your gross charges, right? That's also known as patient service revenue or transport revenue. It's called so many things, but it's the gross, it's the menu price, as I mentioned earlier. When you then subtract from that any contractual allowance, that's you're contractually being written down by the payer to what they actually are going to pay you. And it depends on the payer. This might be 15%, it might be 72%. It doesn't, you need to know what your payers are doing. So that's your contractual allowance. And you want these broken out because you want to understand of these categories what's going where for your organization because it helps you manage also your whole revenue cycle from start to finish. From there, I'm going to skip reserve and I'm going to end with that one last in this slide. We're going to go to bad debts and write-offs. These are non-collectible accounts. Now, I am not a fan of like full-on write-offs. I hate sending people to collections, but I do think there's some opportunity to work the claims a lot more better difference before we get to full bad debt write-off territory. Again, going back to my earlier comment about lazy, sorry, bringing the word back. I think there's a lot of more work that can be done proactively before we have to go here. Now, there are incentives to Medicare bad debts and Medicaid bad debts if you do file a Medicaid cost report, which you can too. But the thing is, it's only 65 cents on the dollar. It's not really worth it in the grand scheme of things, right? It's kind of like tripping over dollars to pick up pennies. You're way better off coming up with a patient payment program. Because most of the time, this is high deductibles, the deductible, or out of pocket, or if it's a self-pay patient, right? So you as an organization need to evaluate your financial assistance policies, your financial write-off policies, your payment policies. A lot of people are so stringent on this, they're not willing to really evaluate those different things that you have inside your organization that would make it a win-win for everybody. Yes, sir.
Payment strategy is a great idea, but I'm interested in your experience because a lot of EMS agencies I talk to, whether it's the balance, it's unpaid balance, we're just not successful in getting payments consistently from patients.
I hear that a lot. I hear that a lot, but a lot of the time it comes down to the conversation had with the patient and how the follow-up happens with the patient. You usually could run an incentive program. So I just did this for another organization. We had a huge self-pay balance. It was continuing to grow. It was alarming. Like I wanted to puke, let's just be real. And so what we ended up doing was like for the whole last quarter, because we know it's the holidays, we're going to do some additional discounts. And so we did a campaign for all of our patients. We called each of those patients individually and said, here's the deal. We know it's the holidays. We don't really want to send you to collections. We don't want to do the following activity. We're going to give you a 75% discount for the next 3 months to pay us in cash. So I'm going to tell you right now, if you send it to collections, you're getting 13 cents on the dollar anyway. Because you're paying the collection agency, you're not going to, half the time they're going to be like, screw you, you sent me to collections. And so you can come up with a really cool win-win program. Yes, sir.
But if you're talking about a deductible and co-insurance, aren't they contractually bound? Are you breaking federal law?
Not that.
Unless you have a tax that could potentially cover that?
You are correct. Yes, you can't do the high deductible plan. And if it's a transfer to patient though, because like an AVN at the time, or it was a non-allowable transport, then you have the ability to negotiate.
But if it meets medical necessity and everything you don't.
Then you can't really do. Yeah, you have no.
But even though it seems like the states and even the feds with trying to reduce these unnecessary ambulance bills, right? It seems like they're encouraging us to break the law and arbitrary discounts. But if you get a consistent discount, so you're treating all the patients equally, if you will. If you wanted to do that with some of those deductibles, if you were going to offer everybody with an outstanding balance a 25% discount if they pay cash today, could that be legal?
I would have to look up the deductible rules. I don't usually do it a lot for a high deductible health plan, like the deductible itself or co-insurance. It's usually for the self-pay population for that early out.
Okay.
But I do try to do a lot more effort on those high deductibles before I send them to collections, even if it's a long-term payment plan.
Okay.
Now, granted, our current state climate, I'm gonna try to say this without putting my foot in my mouth. Our current state policy advisors, do not like, us to have a lot of wiggle room on the uninsured population.
Right.
Trying to be very delicate because this is being recorded. But I have gone to testify at our Capitol many a times against some of the current initiatives we have, because you're not even allowed to negotiate like the terms in the hospital sector for self-pay patients. You used to be able to, but now you have to follow the hospital discounted care policies, and you have to go through the screening process. You now have to do 18 months. It has to be consecutive 18 months. You can only have two at one time. Like there's a lot of red tape. And that was not the original intent of the bill. I've actually been working with the bill writers to write an amendment to it to fix it. And the same thing goes with emergency medical systems. But right now, the policy climate of our state doesn't encourage that behavior.
But we can go after the self-pay that aren't,
Correct.
right?
Yeah.
Which in our case
Correct.
is probably one of the bigger buckets
You're
that aren't getting paid.
You're correct.
So that we're not bound to any of that, and we can do
Right.
those two accounts.
Correct, because you don't have a contract, and there's no contractual obligation. The whole thing is if you do the other, the OIG is gonna come back to you and you're incentivizing people to do free care with you. That's essentially why his original statement is relevant. And then let's talk about this reserve calculation. This is where another one to really this is how you also check if your billers are doing a good job. I love the reserve calculation. So what a reserve calculation is taking your accounts receivable aging by financial class. So commercial, Medicare, Medicaid, self-pay. I always like to pull out the largest commercial payer though as well. So like most of the time in Colorado, that's Blue Cross right now. Because we have the Rocky transition. And so UHC left a lot of the western side of the states markets. So we saw a huge Blue Cross uptick on the exchange. But anyway, pull all of those out, classify it by DNFB 0 to 30, 31 to 60, 61 to 90. I usually do 90 to 120, and then after that, all lumped in a bucket. And then from there, you run an analysis on how you're getting paid for each of those financial buckets. Now, some of you, your head just spun and smoke came out your ears. This is why you have an accountant or a CFO or controller or whatever their function title is. Have them run this analysis and say, okay, go in and pull the patient service date, the date of actual payment, figure out what age bucket it would have been in, and what percentage that payment was of the total. So usually the longer it sits in the aging, the less you're going to get paid. Because you've got line item denials you're working, you've got appeals that are trying to be worked through, all of those different things. If you are consistently then seeing that you have a reserve, you have to reserve for future bad debt, future write-offs of a really high dollar amount, it means your aging's not being managed effectively. Because if your aging buckets are consistently growing and they're not falling off, meaning you're not writing off claims that you know you're not going to collect, you're not coming out with an early out program for your self-pay, and now you're at 90% uncollectible because it's over 120. If it's over 180, it's definitely like 100% not collectible at that point. Then you know your reserve calculation is going to be really high, meaning you're going to take your menu price of $100, you're going to add a reserve of an additional $20 on top of the contractual and on top of the bad debt to bring your net patient revenue down even lower because you're not going to get paid for that future revenue. And if your reserve has to keep growing, you've done it wrong. That is a huge indicator for me on billing, because that's when the lazy term comes out to play. I'm picking on you. I'm sorry. You just said you had a visceral response to my choice of language. But the whole point is, right now I'm working with a billing group in a hospital, and I tell you, these girls babysit. I have to babysit them every day. Like, hey, this report has not gone down. This report has not gone down. And the thing is, it's because my reserve has not changed. I can tell as the CFO, my reserve has not gone down, which means they're not cleaning up my old aging. But yeah, if I run my 120 and older, there's a whole bunch of crap sitting in there. Clean that stuff up. So if your reserve is high, you got bad billing practices. If you're doing billing right, reserves should be very little. Because your AR would automatically reflect it. Right? Because your contractuals would automatically be built in. You know what your bad debts are going to be. Things like that. So it should be relatively consistent on that front. Questions on that? It's a loaded statement. Y'all are gonna make some really people happy when you go back to your offices, I can tell. Okay, so this is definitely from the hospital lens, but I still want to go through this slide real quickly because we did a really cool billing training yesterday, but I love talking about all the aspects of billing because a lot of people don't realize what goes into it. So you first have either a patient calls and sets an appointment or they present at the ED. In your case, you get the 911 call. You've dispatched. Okay. The demographic capture moment here will make or break the rest of this whole billing cycle trend. And a lot of people don't realize that. Like we treat our secretaries or the patient access or patient registration or the follow-up crew as like these $12 an hour, which is probably less than minimum wage now that I say that out loud, job roles, when in all reality, they're the most important freaking role in the entire game. If you don't write that freaking patient name down correctly or address, you can kiss all of the conversations I've just had with that. Okay? So you have to catch the demographics. From there, they do an eligibility check. Does their insurance and everything that they just provide you, are they eligible for the benefit of the service you provide? Now, granted, half the time this is in arrears for you guys. So this, yeah. Well, not always. If you're doing a scheduled transport between facilities, it's not always.
We do schedule transports and gets paid ahead of time.
No, you still do it at eligibility before you do that.
Yeah, okay.
That's what I'm saying. That's not cash. Yeah. No, I'm like, no. We do this for all my hospitals. We're required to now.
But the transfers are coming out of your facility, so your staff can do easily that pre-certification, if you will. But if you're an outside entity going to
But if you're booking it, if you know it's coming, you should be having a conversation ahead.
Which means connecting your call takers to your billing office.
Correct.
And having a good working relationship.
Working relationships.
So let's
Slow
talk
down.
about the practicality of that. Most EMS agencies, it's transfer comes out of Pikes Peak Regional Hospital. Ambulance go to Pikes Peak Regional Hospital to pick up that patient.
At 6 a.m.
Ooh, at 6 a.m. Your billing company's closed. You have captain on maybe, but who does that eligibility before? Because granted that you could argue if that is a scheduled transfer or not. Because at least, I mean, they call it advance, and if it's not a really serious, you have a little bit of time to get up there, but who does that?
It doesn't have to always be your billing company. So I'm gonna push back on you a little bit.
Okay.
I have techs making eligibility calls.
Which one?
I have techs. They'll log into the insurance website and do an eligibility check.
So the EMT on your ambulance will log into the insurance.
CNAs, MAs,
Well, I would do it for call.
You what?
call taker.
Call taker.
But I mean, that's county dispatch. And we'd love to go to Crawford County SO and say, I mean, that kind of, but it's like, I'd love to figure this out.
So I guess maybe what will help
I'm gonna
is,
call Russ at 6 a.m. and say, you know.
but what is the definition of scheduled? Because so we're talking about interfacility transport at a state level and holding transports till they're safe, okay? Now, are we putting that transfer or transport now in a schedule because we're sending a crew up there at 8 a.m.? Or I would argue that they're going from a critical access hospital at either one of our agencies and they're going to a higher level of care. So I would hope, and I may be wrong, that that's not a scheduled transfer. That is actually a continuum of care to higher level of care, not the appropriate facility.
Correct.
So what's the
I would
difference?
argue y'all are making this way more complicated than I was intending it to be. My whole point is, if you have any advance notice, I would highly encourage analyzing your staffing time. We have downtime in EMS at times. I want to be very clear about. We have certain players call people. Maybe it's not a call; it's a call center. but maybe there isn't an administrative staff member. Maybe it's somebody that's sitting back and waiting for the next call out while this other crew is being bussed out to go do that transport. You can cross-train this function. You could do it after the fact too. I want to be very clear about that. But the lack of doing this front end work makes that poor lady's back, her hair turn even more gray and she loses it. I know that's because we were talking about billing earlier, so that's why I'm picking on you. But my point being is like the front end is so important. And I would highly encourage the rethought process around the front end. I know I'm making a lot of you like literally want to throw tomatoes at me right now, but point is this is why the insurance companies love not paying you off.
If I may,
Please.
when we began putting Pulsar into El Paso County, and many of you are aware of Pulsar and what it does. The biggest holdup was the registration people at the facilities. Because they demanded that information, the demographic information, immediately. They were not willing to wait. Am I right, Carrick?
Oh, you're on.
That was
Well, we have to take a
huge.
photo of their name and attach it before they activate anything.
And I guess my point is that's to demonstrate the hospitals, and these are big hospitals, they recognize exactly what you're saying, and that's why it may be worth looking at how to do this.
Well, and it goes back into the casualty claims. You know, there was a way that we could strategize even before, I don't know, a trip report is, I don't know if you can do it, even before the trip report is done. To get to Russ, a traffic accident, and I don't know if you can put a hold on that, or it's a first claim against that med pay. But somehow we've got to be you, the hospital, to that med pay. And the way our processes work now, we're never gonna get that med pay.
Right, and so this is again, I love the mention of AI earlier, because I think there's so much it can be used and good for. I have a not so great impression of it right now for some other reasons, but I do think there's some automation and some systems that you can put in place to help with a lot of these pieces, because it doesn't always have to look a certain way, okay? I'm mentioning it though, because when I do my deep dive analysis on almost every district, the front end is what kills the back end. Yes, sir?
So one thing that we've done is we're using Contexture. So the health information exchange, and our office manager can also go and beef up that front end too. And I'm kind of curious what you said as far as the MedPay stuff, because I believe we're getting that, but we're every day that Barb is in the office, she is shipping those things off daily, and which I'm sure most people are. So obviously there's some time frame, but we do not count on, I guarantee you, we do not count on the ward clerks at the ER to get us information, because when they go in, we bring a patient in, we know we picked them up at XYZ Main Street and their address is some county road in Aguilar. They've changed it. They don't take the time. So I've always felt that our hospital is way shitty, pardon my French, giving the information. So
Technical terms.
So ultimately we've had to change that to do that, and Barb absolutely loves that Contexture and can get all their information.
But their lack of efficiency is working in your benefit, especially for casualty claims. The efficiency of the UC Health and the Common Spirit systems is hurting me, mining.
Correct. And that's the thing. The name of the game is process improvement in all of this, right? Like Lean Six Sigma at its finest. This is the Kanban system. Throwing that out there. Again, I nerd out on all of those kinds of things, because to me, this is all just, is there a better way, more, better, different, that this can be done to be able to capture this information? Because even then, from there, you now have to have somebody to work any non-verified that come back. Because half the time, the insurance card you got was expired and the patient didn't even realize they gave you the wrong damn one. Right? Or if you're in really rural area, good luck if they have their wallet on them. Right? Like I see this all the time. Then from there, the patient is transported, seen, care is delivered in some capacity, and documentation is prepared. this documentation piece is super, super important as well, because obviously if you're not documenting, the whole, if it didn't get charted, it didn't happen mentality is legit. Right? And as much as we want our electronic health records or whatever system you're using to have really cool smart phrases that automatically populate this stuff for you, last time I knew, most standalone facilities can't go out and buy Epic by themselves and have it pre-programmed stuff, right? So the documentation really matters. Then obviously it's marked done by the service provider at that point, and it goes into some sort of billing, coding, and counter review. This scrub. A lot of this time, this scrub does not happen. A lot of people are trusting the electronic health record to just shove it out the door and flag it. You want to talk about like giving me heartburn? This, right? I am a trust but verify person. Sorry. So you want to have your counter scrub. From there, the coding and billing team might have questions. I say physicians, but it's the same. They're going to come back and say, hey, this transport doesn't have all the documentation. My favorite is the ones that all pile up and you wait till the end of the month, and then you shove it in front of a biller's face. They're trying to cram through a whole month's worth of transports, and they're like, screw it, I'm just going to shove that one through. They're not going to spend the time going back to you because they're trying to do 30 days in one sitting. I see this all the time in our little rural areas, because again, we all have tons of staff, right? Okay, then the billing goes to claim to bill, submitted through the clearinghouse. First pass denial, so if there's an issue, goes back to the billing team to rework, whether it's line item denial, figure out if it's what the denial reason was. Is it a demographic, medical necessity? Is it benefit doesn't exist? Is the benefit not appropriate? Is it, this is a secondary insurance instead of a primary? What is it? Like, what's this denial reason? They're then going to do a practice review of that, resubmit that puppy, get the payment then remitted, has to be posted to the right patient account, because God forbid that doesn't happen right. You'd be surprised how bad that actually gets messed up. And then from there, the deposit log is updated, and then it gets reconciled into the bank and the finances. But you can see how many pieces could go wrong. And going back to your billing comment about measuring your billing time, every one of these should have a metric. Is your EMS staff sitting on stuff that they're not sending to your billing team? Sorry, preaching to my biller back here. My point is, like, you need to know these metrics, because the longer they sit, the longer you have a game of timely filing. Right? And so this is why I love this slide. Hospital or no, it all applies. It's the same thing. Yes. So we left off on this slide last time we were talking. Again, the whole point was to prove that there's a million different steps in the billing process and how you should be monitoring every phase of this process. And again, it depends on your role within the organization, but a lot of people don't put weight on the front end. Like I was saying earlier, they put a lot of weight on the back end, but when you're on the back end, you're very reactionary. Essentially, you're sitting behind a home plate with a catcher's mitt, hoping to God they're throwing balls in the right direction, right? To me, when you're working the front end, it's a lot more of a proactive approach around billing. And so, I don't know. Like I said, I love this slide just because it shows so many pieces. We were talking actually afterwards in a sidebar, and really there should be more arrows on this slide than there are. Because if there's an error here, like the documentation's not prepared, it has to be kicked back to the provider or whoever was providing it. Or if it's not verified, it has to be kicked back to eligibility. And so you can literally spend hours or days or months in this cycle over one claim. And so I don't show all the arrows on this because, again, I threw this together last night when I changed my mind on what I wanted to share with you all today. But again, I still think it shows a pretty good framework. What I'm going to share here shortly is the flip side of this coin. So we were talking a lot about revenue production, but there's still expense management. The expense management has the same workflow, right? As money goes out the door, you have to manage that workflow effectively as well. There we go. All right, so obviously we have to play with the payers and the different behaviors. So we talked a little bit about this. There was a really great, like I said, presentation yesterday on the Advantage plans. Interesting. Advantage, I was in the hotel room last night, and I don't know if y'all scanned the TV channels at all. There was 4 channels last night on selling Medicare Advantage plans. Humana had a channel. I mean, I was like, oh my God, what the heck? Like, and that tells you how bad they're hitting the market. And right now is open enrollment. And the reason I'm bringing this up is there's an opportunity for any organization to do some patient education. And so I don't know if what your relationships are. I heard there might be some strong relationships over here with some critical access hospitals, but point being, if you have a relationship with any other care provider, they're doing campaigns right now to help educate their patient population around the not so great advantages of Medicare Advantage. Great opportunity for you guys to get on the same bandwagon and be a part of that patient education. I know St. Vincent is a great example. We just did community coffee for 4 weeks in a row, educating our community on why Advantage plans might sound great in theory and why they're actually not good in community. And so it's okay to like have those educational platforms to help your patient population understand the use of these different items. The other thing is, now I know the EMS side of the coin does not get the same benefit as hospitals when it comes to charity care or community benefit, but y'all are often listed on the community benefit report for the hospital. I don't know if you're familiar with community benefit reporting at all, but ultimately we're given thresholds or spend requirements on how much community benefit we have to provide at a hospital level. And that does include transports, right? And so if you have a say in those conversations of how much quote unquote free transport you want to do from a charity care lens, those that would be on a sliding fee scale due to their financial situation, you might want to be at the table when it comes to those community benefit reports, right? So that way you can have a conversation with the state, because the state from governmental side of the coin is very uneducated around how much free care actually happens. All they hear about is the big bad hospital systems that charge a bunch of money and make a bunch of money, and that profit's not shared with them or the constituents. But in all reality, if you were to look at the population of patient care in the state of Colorado, most hospitals are barely break even or better. There's only the larger systems that are showing those profit margins, but yet everybody else gets caught in the wave of the regulatory environment around charity care, free care, self-pay. And so that's why I consistently bring up the payer mix. And I will still, I know he's not here to pick on, so I'm going to pick on him when even though he's not here to defend himself, but still argue you would want to look at your payer agreements and really look at whether or not you should have those contractual relationships or not. Again, financial data for decision making. We had another sidebar out in the hallway after the last conversation. Because a lot of people think that you need to be in complicated systems to have good financial information or data. I want to call bullshit on it. I took St. Vincent Hospital. This is a great example, but I've done it many times over. They were on Infor, the platform, paired with Athena as their electronic health record. But Infor it's costing them $275,000 a year. Very clunky, wasn't useful. I literally took them off of that and put them on good old-fashioned QuickBooks. A hospital on good old-fashioned QuickBooks. I know that there's some hate around it because it's really not governmental driven, and the funds and all of that fun stuff gets a little bit more complicated. Going back to my first statement when I started the presentation this morning, the data is not so simple that you can't understand it. What's the point? Right? And so I firmly believe, like, you could put really, really large organizations on simple platforms. So when we're looking at the financial data that you're using for decision making, simple, simple, simple. Like, the more simple you can make it, the better. And honestly, from a grant lens, this is actually another great thing when it comes to the narrative. Because again, half the time the narrative doesn't match the numbers, right? But if the numbers are so complicated, they don't understand the story, it's really hard to craft the narrative around it. So the simplified method actually works because again, most people don't go to school to be accountants, or y'all would be accountants, right? From that. In addition, you want to bridge the gap with any of your leads, supervisors, or managers. So depending on how many levels you have within your organization, maybe even crew leaders, you want to make sure that there's some sort of financial education at that level. I mentioned it a little bit earlier in the presentation about buy-in, but I don't even do budgets for departments or budgets for organizations without going to the front line and asking questions and having them fill out budget questionnaires. and surveys. Because if they don't feel like they had input in that process, when it comes to getting that stuff shoved down the pipe later, you're gonna be like, hey, darn administrators again, or the executive director, or the chief wants us to do, and there's no buy-in. But if you are getting them understanding the process and you interview them through those questions in that process, and they understand their actual impact in the financial story, then from there, you're a lot better off to gain the traction that you need financially to move the needle forward. I also, again, I love budgets and rolling forecasts. I know people cringe when you hear the B word because everybody thinks restriction and permission to spend, bless you, in a certain area. For me, though, they should be flexible. So I know we have the state mandatory requirements of submitting your budgets and et cetera that are like the compliance side of the coin. But when I put together forecasts, we put them together in a way that allows for us to go in and update that for what's actually happening later. So if it's volume driven, patient driven, you come to me a month in and you're like, crap, Kelly, we originally budgeted for XYZ number of transports, patients, acuity, etc. And you're like, the picture's changed. We should be able to go into that forecast, adjust that picture, and know where we're going to land by the end of the year. It shouldn't be a one and done project that you put inside of a desk drawer when you're done. Like, it just drives me nuts. It needs to be a tool that can be utilized every single time. And it pairs well with the revenue cycle management and all of those pieces, because if you're off point in one area, again, as I mentioned before, if you know about it now, you have 60, 90-day cycle to react to it instead of waiting until it's too late. I mean, every single hospital that I have done financial turnarounds for, they were in such a reactionary state because they didn't proactively manage the data. They waited for it to come to them on that. And then you want to layer this with key performance indicators that are leading indicators. Does everybody know what a leading indicator is? No?
Early indicator?
I'm sorry?
Early indicator?
So give me more. What's an example of one?
Leading indicator of economic downturn is decrease in number of people that go to a movie.
Okay, yeah, so something that's a precursor to, right? So in your guys' industry specifically, or in healthcare in general, what is a leading indicator that crap's not going well? Huh?
Your payer mix.
Okay, so maybe you have more of one type than another. Okay, that might be one. What's another leading indicator?
If you're a destination, changing in the number of, or the type of events that would be coming to a destination.
Okay, yeah, so possibly events or, yeah, so like Leadville's a great one. If the Leadville 100 were to leave, that would be bad. Because that's like, otherwise it's shoulder season there, right? So it's always race season and not race season. If race season ended, that's the only tourism that comes to Leadville, right? It's not like Telluride where people go there to go to Telsky. It's very different, right? So that would be one. What's another leading indicator?
Tying into that, decreased call volume,
Call volumes?
transports.
Right. So the whole thing is you want to make sure you have a dashboard that is that far ahead, right? You don't want it to be days cash on hand or days in AR. Those are after the fact. Those are reactionary. Don't get me wrong, you want to know those numbers. Those can be on your dashboard, but they're so far, like they're behind the 8 ball, right? Because remember, cash is a 90-day lag. You want something that's going to tell you before the 60, 90 days that cash is going down. So you need to figure out what dominoes have to fall related to that. Overtime might be one of them. How many additional overtime shifts are you asking your team members to cover? Which means payroll costs are going to go up, as well as you might have a staffing indicator, right? Like what's capacity look like? How many open shifts did you have to beg people to cover for? Right? These are legit problems that if you had some sort of leading indicator on a dashboard for, you could get ahead of future issues within the organization. And like I said, it's amazing to me. You all are really good at data capture in the EMS space as a community, but at the same time, you don't always use it to your advantage, right? So I mean, some of it might be manual because we're not quite using ChatGPT to do all that kind of stuff yet. But my point being is like, I almost every single EMS director I talk to will give me all these stats, and I'm like, well, crap, you have everything you needed all along to be able to make those decisions. They just don't know like how to leverage it, right? So you need to know what the impact of those changes are before those changes actually happen in the dashboards. We kind of already talked about this, but let's still circle back to understanding how to read the financial statements and stuff you're given. Kind of fun discussion because a lot of people don't really understand the way accountants book things. And there's this whole thing called accrual accounting and cash accounting, right? I don't want to get into a full accounting lecture because y'all would fall asleep this on a Friday afternoon. But the point being is you should sit down with whoever is doing your financials and actually do a deep dive training on how to read what is being produced for you. Because also, as black and white as what people think accounting is, every single accountant I talk to has a very different interpretation of accounting. It's actually the most grave thing you'll ever know, even though you would think it's just numbers. But everything, there's a lot of estimates, right? Reserve is an estimate. Depreciation is an estimate. These are all fake numbers that are essentially on your financials that have no direct impact on cash. And you can have no money in the bank and have a really great profit and loss statement, or you can have a bunch of money in the bank and a really crappy profit and loss statement because of the activity that's playing on a balance sheet versus your profit and loss. If you don't know the relationship between those two statements, you might be misled, right? I have organizations all the time that are maybe on the for-profit side, for lack of better words, that will have great profitability, and then they get mad when I tell them they have a tax bill at the end of the year. I'm like, well, they're like, I have no cash. I'm like, yeah, it's because you spent it on things that are not on the profit and loss. And Uncle Sam doesn't care about that part. Like you're going to be taxed on what's on the profit and loss. Say it's the reverse in the nonprofit and governmental sector. We spend money on things that might be like liability or debt coverage, debt service costs, but yet our profit and loss is showing that we should have more cash in the bank than we do. And so we just need to understand the relationship of those statements and how to leverage that information to really make good decisions. And I know it might feel embarrassing or uncomfortable. And if your accountant doesn't speak English, you can slap them around and find somebody who does. But the point is, you really do need to understand the reports that you're given on a consistent basis.
If I may.
Please, yeah.
So I sit on a committee at the state level where if you are applying for a grant, you're able to, it's a 50-50 match. You can apply for a waiver of the 50% cash match. So I have always asked the state, can you give us some guidance, some benchmarks as they should have this much in revenue. They should revenue over expenses. And they would never do that because it truly depends on the individual agency at this point in time. And that was always very frustrating to me because I am not an accountant and yet I'm being asked to review someone's financials.
Correct. And it's really frustrating. So this is why I like going back to your snapshot in time conversation. So most lenders, grants, writers, etc., play in the balance sheet space. So that's a snapshot in time that includes the whole history of the organization. So if you have an organization that's consistently driving losses, their equity is going to be negative, which means essentially their net worth's upside down because they have more liabilities than they have assets, right? And then you're going to look at liquidity because in a balance sheet, assets are listed in the order of liquidity. Cash first, then what you can bill for, receivables, followed usually by fixed assets or inventory, followed by like investments that are hard to unlock for the sake of use. And then liabilities are always listed by current then long term. And so you want to leverage that balance sheet because that'll tell you a snapshot of health. But I was talking with Brandon outside and he was like, well, the crappy part is there's times when I really do want to go after a grant or a specific project, but I might be liquid and they're going to be like, well, you're already liquid. Why would I give you grant money? But he's really after like the relationship or maybe the actual program itself and not necessarily quote unquote the cash. And so you have to be able to make sure your narrative matches the liquidity or the liability stacked in that particular balance sheet. Could you compare that to the profit and loss? which is like your income and your expenses, the profit and loss is for one period of time. Right? It's usually a month, a quarter, or a year. You don't see it span more than a year. And so those operating cycles will have ups and downs, comparatively speaking, and it's really hard to know like how the company's doing in an operating cycle because we've all had a crappy year, right? But if you look at the balance sheet, you can actually see the accumulation of whether it's been accumulation of crappy years or good years, right? St. Vincent was a great story. That's the hospital that's circled the drain like 4 different times, right? If you look at their net worth, it's finally positive, guys. It only took like 3 years, but it's finally positive. But this is finally positive and it's been around since the 60s. Like, it was around way before that under Sisters of Charity and even before that. Like, it's finally now positive from an equity lens. Like, that tells you how many years of bad operations there has been, which is essentially not a good risk. So this is a snapshot of like just an example of them. I like to put them in here. Balance sheets are not shared this way anymore, but back in the day, and when you did actual accounting classes, balance sheets used to be listed assets on one side, liabilities and equity on the other to show that it actually balances. Because that's what a balance sheet is. It's a balancing act, aka debits and credits, right? But I like looking at it this way because it kind of tells you specifically what you're comparing for the organization. But you should be able to pull this information from whatever system that you're utilizing. And even if your funds are commingled with the county or whatever, I see this all the time in districts, you should still be able to extract the specific cash that is related to your entity. It should be restricted on the county's balance sheet under restricted use because they can't touch your money, but they're the custodian of it. And then your cash number should reconcile to their restricted number at all points in time. But the commingled funds tends to be a little bit of an issue when it comes to emergency districts specifically. And they can literally be this simple, guys. I'm throwing that out there. I know that we talked about how they can get really complicated, like audits can be 80 pages. They don't have to be that complicated. So I'm going to share this exercise with you. We won't do it today because I want to give time for questions and stuff at the end. But I would challenge you to go back to your organization and draw this bullseye and go through the exercise of actually filling this out. So if this, if I'm analyzing my company and I want to determine priorities of expense and the revenue I need to generate to cover them, I'm going to look at it from a holistic lens. So the center of the bullseye should be the most important expense for your operations. So what do you think that would be? Payroll. You're humans, right? Humans are the most important aspect of that. What do you think the second most important expense would be?
Insurance,
Benefits, right? Usually something supporting said staff. What else did you say?
The capital, the equipment,
So equipment, supplies might be. So central supplies, equipment. What do you think the third or fourth rung might be?
Sure.
Like, so maybe liability insurance. What else?
Facilities,
Utilities, taxes,
maintenance.
Right. So what should happen is on the bullseye, the closer to the center should be patient care centered. And the further away you get from the center, it's supporting that patient care, right? I love to do this for hospitals because like in an ED, your number one cost is your salary and wages. Your second is usually a professional fee. So if you contract out anything, it's that professional fee component. Then from there, it's your purchase services. So things that are like service contracts to keep your equipment and functional, things like that. Then from there, you do get into your central supplies. Then from there, it's utilities, repair and maintenance, rent costs, etc. Right? And you keep going through all the layers of your bullseye until you're down to the farthest rung of like the fake numbers that accountants come up with, right? Like the depreciation, amortization, all that kind of stuff, right? Because it's not real cash. The IRS says a car lasts 5 years. Last time I checked, I can make it last a hell of a lot longer, but that's what depreciation says, right? Those are fake numbers. So those go on the end. But the whole reason you do the bullseye effect is when you're looking at cutting costs, or if you have to make a quick change, you can start on the outer rungs and work your way in. So many people cut the wrong cost first. And I'm a firm believer you can't cut your way out of a crisis, which is why I start all my conversations with the revenue cycle first. Because in my opinion, if you're spending the money on the expense, you should find a way to make it make you money first. But then from there, you might have to button down on certain expenses. And so the bullseye helps you kind of prioritize that. And then your revenue, I always tell people when we do this exercise, I actually make them write this out. Like I said, I won't make y'all do it, but I will make them take and draw their revenue, the net revenue, as the dollar sign above the bullseye, and it needs to cover the whole damn thing. So if your charges are not high enough to cover all the way to the outer rung, you're already upside down, and then you're going for gap funding. Yeah.
So just wondering, even your philosophy, and even community integrated health, global integrated health. So especially a lot of these larger communities will get into it, not necessarily because it's making money, but because it could be saving you money somewhere else. How do you reconcile that?
That's a good question. So
Saving you money or saving
So,
payers money?
so let's just use CSFD for an example, their CARES team. So if you see this repetitive patient all the time and resources are running out to this particular patient multiple times a week, month, or whatever, if you can somehow mitigate that patient's overuse of the EMS system through their CARES team, even though their CARES team may be grant funded, but there really is no patient, Humana doesn't pay for it, Blue Cross doesn't pay for it, Medicare doesn't pay for it, but how can you make that connection of the savings that CSFD or the city of Colorado Springs might be experiencing because they have the CARES program?
I love this question because I'm going to tell you right now, most ambulances tied to a hospital don't make money. But you need an ambulance to get your ED populated to make everything else make money. Oncology does not make money, but if you measure how much money it gives your lab, your imaging, and all of that, it makes you a hell of a lot of money, right? So there's trade-offs for some of those lost leaders. And you have to, how you measure the savings is you look at the additional costs that you've incurred, multiple transports, increased salary and wage time. Because now you're running crews at multiple times. Repair and maintenance is going up on your buses in order to cover for those additional transports. You can literally quantify that data and then compare it to the pittance of grant dollars it's going to take take care of that population to stop draining those resources, and the savings is astronomical. I see this all the time in population health. Home health is a huge argument. Actually, really get frustrated why we stopped funding for those types of care, because in the hospital system, you're paid on a DRG unless you're cost-based reimbursed. You don't want somebody sitting in your inpatient sucking up resources, and then they yell at you for increased cost of care, but yet we won't pay for home health. Sometimes it's easier to kick them to home health, take the hit financially over here to free up that bed for a higher acuity patient to get you a higher reimbursement. But you have to run the numbers to prove that model work, right? You still have to, in the cost savings factor, the cost that you save still has to outweigh the cost that it does to increase to have that care. And you have to quantify it and prove that story. And you can. It's kind of like trying to think of the best relationship or the narrative. The easiest, I think, comparison would be say you're going to get really nailed to a wall on your tax return this year. We've all been there some point in time, right? You're like, oh crap, I didn't pay enough or have enough withheld from my paycheck, right? I'm going to go out, I'm going to start a small side hustle and I'll buy a truck, right? To not pay taxes. But really, you bought a truck to save 35 cents on the dollar for tax. Is the truck really worth it, or is the tax savings worth it? What's the tipping point of making that truck investment actually worth it? It's the same argument, right? Like, I know that's like really weird to make those parallels, but the whole thing is you have to prove that the savings outweighs the initial cost of that additional patient care. But it is provable. I've done it all the time. Yeah, you have to. It's a lot of data to run, but if you have people draining on the system, you have to fix that process. But at the same time, On the flip side of this, our healthcare system is broken to a degree where we have to speak up about where that part doesn't work either. So what I mean by this is, I'm going to use my husband as an example. My poor husband gets used as an example lots in class, but he's never here to defend himself. But the other day he hurt his back, right? And me being the healthcare professional, I'm like, you've been complaining about your back for 2 months. It's really like an emergency. This is not an emergency situation, right? So I'm like, okay, you're going to go to urgent care because we knew we needed imaging. And it was, of course, a Friday evening. So it was after hours. And I wasn't going to, like, docs on call wasn't open, etc. We're in a smaller town. So I was like, you're going to go to urgent care. Well, he went to urgent care to keep the cost of care low. He was an educated patient, which we all know how few those are, right? And urgent care turned him away because it was potentially related to work, and they were afraid of workers' comp claims. They were like, hands off, you need to go to the ED. So then my poor husband, we go to the emergency room. He's one of those patients bogging down a waiting room that's unnecessary care in an emergency room, just jacked up a huge bill over a stupid x-ray that could have been a $1,200 cheap little x-ray over here, but now it's an $8,000 experience. Granted, we have insurance, so that's all covered, but cost of care is not it's not the right level of care, right? And so knowing this story, the first thing I did after watching my husband go through it was take pictures of everything and send it to Kim over at the state and said, I tried to keep your cost of care low, but your system didn't let me. And so in this particular case, you're trying to keep cost of care low by not sending additional buses to something that doesn't need to have emergency care. But we need to share that narrative over and over and over again until others start to understand that narrative. Otherwise, we're the big bad guys in the room.
Because one of the problems we have is creating that value narrative, capturing the cost savings reliably and validly, so that somebody at Humana will get it. That's one of the problems we have.
Yeah, if you can run the data set and actually prove it, which, like I said, you can, it's the narrative is there. We just need enough people to keep saying it, if that makes sense. Because right now, people think that patients are ignorant and we're all the rich and selfish healthcare providers. Last I checked, most aren't, right? But that's the narrative that they know. So unless you prove otherwise that you're trying to do an alternative methodology, they don't care. But there is a way to prove it. So again, I love the bullseye because it kind of gives you a framework to work within. I do this for all small businesses too, by the way. So if you have like small business side hustle, one of my favorite exercises as well, purely because again, it's a great way to know what's unnecessary or not as priority of an expense versus your priority. So this is the expense cycle side. So I mentioned last time the revenue cycle side. I think this is super, super important to walk through because again, we don't give a lot of value to understanding all of the expenses that go out the door. And I don't know how to turn off my stupid Teams notifications right now, so I'm sorry. But anyway, the first thing we need to do is obviously evaluate the need and budget for a specific item. So going back to my conversation around forecasting, it's so, so important to put together your game plan for all spend. Now we understand that like things fluctuate, volumes fluctuate, transports fluctuate. So you're gonna have some variable components to costs. But for the most part, it's pretty straightforward. Most of our costs in any sort of healthcare are fixed. Salaries are pretty darn fixed, with the exception of covering some call or things like that. For the most part, most people work 40 hours or crazy 7-hour shifts, like all the different things that we do at EMS, because y'all mess with total payroll mess. But anyway, the point being, it's pretty consistent. And so those are fixed costs. So you need to make sure it's evaluating the need from a budget perspective. Then obviously there's a requisition process. Now, some of you are a small organization, you're like, that's cute. I just call my vendor and I order the stuff, right? Or I go through my bookkeeper and they do it for me. But there should still be some sort of requisition approval process related to what your budgetary need is. Oftentimes in the smaller facilities or organizations, people are not tracking their requisitions to the quantity that they're spending. And so as a result, they have no leverage when it comes to negotiation with vendors. right? Hospitals have levers through group purchasing organizations. Now, small EMS districts can jump on that bandwagon to a certain degree, but unless you can prove the volume of spend with vendors and how you go about doing that spend, you have no leverage to get a reduction in costs. But I can tell you right now, you can argue Henry Schein, Cardinal, all of them all day long and reduce those costs. It's quite fun, actually. Because the thing is, again, just like payers, they don't expect the little guys to do the same when it comes to expense management. So if you have a solid requisition process and a purchase order system or some sort of way of tracking those purchases, you could negotiate cheaper vendor relationship costs. From there, obviously you do vendor negotiation for your purchase. I personally also love to make my vendors wait to get paid 30 to 45 days minimum. Most of the time I want 60. Why do you think I want those days?
Collect payment for the services.
Right, because you don't get paid unless it's Medicare, 14 and 21 days. That's the time I told you, y'all are banks for 60 days. So if you're not getting paid for 60 days, why would you float the costs then? I mean, you're already floating payroll. So if you can push your vendor negotiations out and kind of align it a little bit more with your revenue cycle, cash flow looks more like an actual regular heartbeat instead of a heck of an irregular one, right? So I always like to think of cash flow like a heartbeat. Because again, healthy is regular, unhealthy is not. From there, when the product's delivered, the vendor will issue the AP invoice. The AP will then have some sort of approval process. You want to make sure you have approvals. They'll make sure it matches the purchase order and the original negotiated rate. Oftentimes, the vendor's invoice will not match the original negotiation. Again, another opportunity for them to be like, they're not going to check. They're not going to reconcile. Right? And I know this seems cheesy, but this is free money, guys. Free money. You don't have to do anything other than just button down your workflow. Okay? From there, they return the approved invoice. The AP then gets it final approved by the executive director, goes to payment, AP check run, payment issued. But again, you want to make sure that that process is so well tracked, you have leverage. Yes, sir.
Could you next time simplify this, the small agency that doesn't have the director or
I mean, really, you're just going to go to, you're going to have a purchase order and you're going to negotiate with the vendor. From there, if it's just you, you're going to wait for that vendor to send you the product and the invoice. Okay? You want to make sure what you negotiated and that invoice match. If they don't match, fun phone calls get to happen. Okay? From there, all you do is then you enter that invoice to be paid according to the terms. The terms on that invoice better match what you negotiated. Half the time they'll leave their old terms on there. 15 days, 210 net 30, whatever it might be. They're going to leave the old terms, but you're going to go back and call them and say, nice try, here's the terms. Then you'll go ahead and do the check run and issue your payment. That's all it is. All you're doing is removing essentially their approvals in here. But you should still have two individuals at least in play in this. Somebody who's ordering and approving, and then somebody else who is cutting the check, and then maybe a third signer, because you want some internal controls here for the sake of you not being in trouble for nefariously cutting checks to yourself. I see a lot of fraud in AP. A lot of fraud. It's one of the easiest areas of exposure. But that's the AP cycle. And to me, again, you need to manage this just like revenue cycle. Yes, sir.
I just want to validate what you're saying, because every single time I've negotiated with a vendor on a product, every single time we've cut the price by 10 to 15, even 25%.
Yes. Oh yeah, they will come down. They just don't expect you to call them out on it.
I agree.
And if you can prove, especially if you can prove bulk, people think this is funny. You negotiate with Home Depot. Like you can literally negotiate with any vendor. They're waiting for somebody to actually do it. Right? So to me, I think it's really, really important. And then from there, one of the other things that people often forget to put in their calculations is overhead. And I always bring overhead in. My favorite is when you're some accounting systems will produce these things called contribution margin statements and not profit and losses. If you've ever seen one, you'll know what I mean. If you haven't, it's a good thing you haven't seen it. That's all I gotta say. But like, the not the, Cerner, Meditech, some of the other bigger systems, they have these old school contribution margin statements, and they'll send them to their different service providers that say, this is how much money you've made and this is how much money you cost. The problem is, it's always lacking overhead and it's always lacking the contractual side of revenue. Right? So it's very misleading data. It actually shows departments making a boatload of money. And it's so funny because I'll go through this exercise with those particular organizations and say, okay, now I want you to manually go in and add this number and manually go in and add this number. And then did your positive bottom line go to a negative, or are you good? 90% of the time their hands will go up for it went negative because they did not factor in overhead in terms of their actual costs for their organization, right? So are you paying for accounting? How are you paying for billing? Is billing based off of a percentage of collections, or is it hourly? Or medical records management. How are you dealing with medical records requests? Marketing, plant ops, information systems, all of those things oftentimes not factored in or taken into consideration when I do that bullseye exercise or looking at the organization's health. And so even if you're running crews and you want your crews bought in terms of their productivity, help them understand what the percentage of overhead that's allocated to their crew is. Right? So for an example, if you know overhead is an average of 12% of the money they make, so 12% of every transport you go out is overhead automatic. And if they understand that, then they can start connecting the dots in terms of efficiency. It's amazing to me how much your front line is actually pretty darn educated and will get involved in the cost saving effort on all of that. But the problem is we never give them the opportunity by spelling these things out for them. Of course, we obviously know regulations is another thing that we have to keep our pulse on. And so really understanding profitability and metrics to be able to pivot for regulation. I know EMS is going to be interesting. There's a lot of good things coming down the pipe and a lot of scary things coming down the pipe. And so the ability to have your data at your fingertips and that speed to be able to react is going to be really, really important. I personally think, I mean, in case y'all didn't know, November 5th is an election day, and that can change a lot of things too, right? Like, I don't know. There's a lot in the air right now, balance-wise. But even then, taking that out of it, there's still an opportunity here, I think, to share some stories. Because I'm flabbergasted every time I go to the Capitol, DC, or our state capitol, and I talk about what we do, how little they actually freaking know. It blows my mind. I mean, county commissioners, let's get down to the local level. A lot of them think they understand our model, and they're clueless. No offense to anybody that's listening that might be running in our office, but point being is half the time they literally think all y'all do is just drive around in a government provided bus, soaking up government dollars, take that's legit what they think. You laugh, but you'd be surprised the conversations that we have, right? And then when they think about, when you've got to remember, those that are in higher office are bought and paid for by certain players, right? So they're only hearing in their ear from the Blue Crosses and the Uniteds. They're not hearing from the little provider on the side of the street, right? And so they don't understand and connect the dots. This last year, I went on a rampage of a campaign talking to every public official I could, because I was getting so fed up with rule after rule after rule, especially in our state, slapped down on us. Because I'm sitting there like, do y'all not understand? We're already doing our stuff with our foot tied behind our back, our hands tied behind our back, and maybe some tape halfway over our mouth. And yet you want us to now somehow miraculously come up with more money to cover for it. Oh, and by the way, you've cut all the COVID dollars. So there's no more additional spend, right? And so the whole thing is, but it only works if everybody says for it. So to me, that's where the associations and organizations and partnerships are super, super important, because the more and more we educate, the more and more those walls start to kind of come down. I'm going to tell you, St. Vincent's failure was the best thing that could have happened recently. And I can't believe I'm saying those words. Because Kim Vimster at the state hated hospitals and wanted to tear them all down. But after saving St. Vincent, she's like, no, they're not all that bad.
They were, St. Vincent's was, I mean, our last EMS to the capital, right, Tim? Maybe 2 years ago.
We had the St. Vincent bill. They
We were-
legit writing a
we
bill.
Talked a lot about that. It was an example of EMS failing.
Huh? Exactly. And now she's like, so all of this hospital that's failing, should we actually try to save it now? Like, and this is a lady who was like vehemently told me to like tear it apart. That was what I was told. My directive when I got St. Vincent was to tear it apart, right? But again, had I not every single evening at 6 p.m. got on a Zoom call with that lovely woman and explained to her why I was doing what I was doing, I don't think she would have changed her mind, right? So how many more stories like that without the failure can we get in front of these people to realize they can impact and help save this particular industry? Because a lot of people are like, oh, just make a single payer and it'll solve it. I'm like, yeah, nice try. I don't think that will either. But again, we have to make sure there's enough voices heard at the right levels for this. Staffing, I know y'all love this one. I'm not going to go into too much here because I could spend a whole 2 hours on staffing, specifically in EMS space. However, I do think it's really, really important to evaluate your models. Okay, I got a lot of flack for what I'm going to say, so don't throw tomatoes, please. But EMS staffing and the way shifts work is kind of crappy financially. Okay. And so the whole like we're gonna do so many days, 24-hour shifts, we'll have sleep rooms, all those types of things, and you start adding up math. Math doesn't math very quickly in this particular sector of the healthcare. But if you really look at it and you get creative and you start looking at your staffing qualifications, you start looking at the demand when calls happen, what type of calls are happening, you can restructure your staffing in a manner that actually creates cost savings as well as actually is a win for your staff. You don't want to lose your crews over the fact that they're going to not have overtime and whatnot. I mean, a lot of them bank on that kind of pay structure. That's why they're in this particular field. But at the same time, there is a way to find that win-win scenario. You just have to model this out. I don't want to, like I said, I can go down a rabbit hole really quickly on this subject, but the point is run the numbers and start figuring out what the modeling is. Because staffing is your highest line item. It's about 68% of every dollar you bring in, right? 68% of every dollar you bring in goes to this. So I would highly suggest we manage it as effectively as possible, right? Yes, sir.
Not to do a plug, but everyone jumped to the conclusion, yeah, think about staffing of the EMS personnel, but think about the other groups within your organization, like maybe billing or other.
Correct. You're leading right. You're right. Teeing me up the next piece. But yeah, we'll come back to that.
One thing that I'm sure you are aware of, but there are many other things that go into how agencies staff than just call volume, things like that.
Oh, there's regulations, there's requirements,
Housing.
housing, all of it.
They can't live where they work,
Correct. Correct.
so you have
You're
to,
going to get as efficient as possible for them to drive to your location, stay with you for so many days. I 100% agree with that.
So tying into that, I would argue that if they're not being utilized, right? If their unit hour utilization is low, that downtime, that time they're not being utilized, that's a subsidy. Is there any way to leverage that subsidy?
Oh, heck yes. Going back to my call conversation, we had debate going on between 3 of you about who does the billing eligibility checks, who does the patient demographic review. Oh yeah, that's called downtime. If you ever want to, everybody like, they're like, oh God, Kelly's here, right? When I make the downtime a productive downtime, if I'm paying you, it's productive. It's very, very important. Yes, sir.
So one of the problems in our is hours work. Larger services, they will staff 8-hour shifts, 10-hour shifts, 12-hour shifts, but the smaller you get, you go into 24s, this is called modified telly.
And the farther you get away from the urban area.
Yeah.
Oh, it
and
gets
then
even
the next
worse,
thing
yeah.
is a lot of folks want to do 48/72s.
Uh-huh.
Well, there's from a safety standpoint, the industry is discouraging 24s, let alone putting people on 48s. And now, if you're gonna leverage those down hours and having them do eligibility and all that stuff, and they're doing 48-hour shifts, doing this, doing vehicle checks, running calls.
Yes,
It's
there's a
very
fine
sad.
balance. There's a fine balance here. And that's where, like I said, you have to model this out. I knew I was gonna get tomatoes. See, I told you they're coming. No, you have to model it because there is a way to make it a win-win. So at St. Vincent, we still do have 72s. We still have 48s because getting people to drive from Denver to hang out in Leadville and then drive back and all the things. Completely understand what you're saying. And at the same time, I've ran enough volume to know how many actual calls there are. You're even during an 8-hour period of time, there's not that. I mean, there's a lot, but not really. Right? You know, I'm trying to not make enemies in this room, but you get what I drive. There's not enough to me where I'm like, oh my God, they're busy 24/7. Now, is there certain periods of time where that is the case? Full moons, holidays, hell yeah, they suck. If you're in emergency medicine, you like, oh God, the tide, like when they were talking about the tide thing, and I'm like, oh, emergency room's gonna be a nightmare. But that's just that you know that those days are gonna be not as productive for other administrative functions. But I mean, half the time I'll go and do tours of the organizations and they're sitting there on the phone watching YouTube, waiting for the next call. Call, make some eligibility, go online and make eligibility checks. You don't even have to call anymore. They have portals for that stuff. So I think there's utilization and there's a balance there. And your expectations need to be in alignment with that too. Right? So like again, in this particular case, we do have expectations. We have so many calls that have to be made, or eligibility follow-ups that have to be made a week. And at the same time, if they don't make that, it has to be signed off on the supervisor that they were too busy to meet that. Check, done, next. Right? And so I think there is a way to balance it. Again, like I said, I knew I was gonna get some tomatoes. But the thing is, you also have to watch the trade-off for all of this because you don't want to also I don't run EMS only thinking about money. Because the cost of actually outsourcing the clinical side is bloody freaking expensive. I mean, we all saw travelers and everything that happened with that whole market during COVID. I mean, you're paying a nurse now 120 an hour plus per diem. EMS, no different, paramedics, all of the different components of that. And so you really, really need to evaluate those pieces. Then you get a layer on top of that, all of the other players and all the other departments, to your point. So you have, you have billing, you have accounting, you have HR, you have IT, you have all of this. Outsourcing can be a solution. There's a lot of fractional service providers out there and or outsourced providers. They can do things better because of the volume that they're doing than hiring somebody in-house. Like coding and billing, I'm going to pick on that for a second. Oftentimes in specifically rural areas, it's very hard to find educated coders that understand specialty and understand the type of billing specifically for ambulance. You know how many really good billers I talk to that are like, I still don't 100% understand ambulance billing, that are amazing billers for like hospital and stuff, because it is complex, right? And the accountability around it is complex. So why would you expect hiring somebody local that maybe doesn't have the experience for them to understand that and stay up on that consistently, unless you're willing to invest? So I want to be very clear about the statements I'm making. Why not go to a company that's all they do? Right?
You're not.
And I'm getting hate from this corner. I'm not going after this corner. Correct. And even though they're quote unquote higher than an hourly rate for an employee, you use them for half the time because their efficiency is 10 times more than what your current staff are. They're oftentimes providing their own IT and additional solutions. So you're not paying for onboarding cost of IT. And then of course all the benefits and all of the other fun legal and remote jumbo that have. Exactly. Their turnover is their issue, not yours. Right? Same goes with like accounting and HR. HR is another one. Right? HR is stupid complicated in Colorado. We're on a race with California to see who makes it worse. Just saying. Right? And so, like, why would you expect an HR person to be able to stay up on that all in all, like, doing a small practice, independent practice, or even small governmental organization when it changes so fast? Unless you're having them attend a webinar every week, good gravy. That's why they have outsourced HR support. Then you can have a point of contact internally that can help manage that relationship. Like, I think of my company, JFS. I have an accounting, HR, and IT supervisor, and they manage the relationship between my third parties for all of that. Like, that's their job, is to coordinate those efforts. Still lower cost for me, right? Because I mean, JFS is in 14 states and 2 foreign countries. I can't keep up with that kind of regulation, right? And so to me, outsourcing as a solution is definitely an opportunity that a lot of people don't take advantage of. And again, they're a vendor. Going back to the AP cycle, called negotiation. You can negotiate with them. You can figure out what that sweet spot of services looks like for your organization. And then, of course, you can be really picky at that point in their qualifications, right? Because I don't know if y'all have tried to hire people lately. It's a nightmare, right? It's a bloody nightmare. You're lucky if they show up on the first day. And so the whole point is like, make it somebody else's problem, not yours. That's my 2 cents on that one. So that was really all I wanted to cover. And so I appreciate you humoring me and letting me come back up here again. But any questions that I didn't cover that maybe you wanted to go over?
Put that last slide back up.
Yes.
Are there questions for Kelly?
Are you taking new clients?
We can definitely, yes. How we do it though, I want to be very clear, is we do a full discovery process to determine if we are a good fit and we have the resources available. And then from there, the first 2 months, we do a deep dive discovery to put together the best engagement, and we'll figure out what that service line looks like. So it's a very specific process.
You can payroll.
Payroll, no, but I do have a kick butt partner in payroll. Yes.
Have you considered, have you considered reaching out to a group like the Savic Buying Group or something and becoming a member, to make your services eligible to folks that are in that buying group?
Again, negotiating, correct, at the time?
I'm not. So here's the thing about my company. So my company came together by accident. I want to be very real. So I was selling payroll. I used to sell payroll for a living, for a period of time. And I got help a hospital during my vacation time because I sold payroll to them, and they're like, "Hey, want to help us convert our EHR?" Sure. And then JFS was born. So I didn't really have an intentionality around it before. However, I'm going to tell you there are some conversations happening with this organization to be able to provide some additional resources to this group. So I just want to like I said, I have a whole online educational platform with on-demand training for department leaders that don't know how to read financial statements. I have a whole online class on how to create a cash flow projection for your organization and how do you leverage that. I'm a nerd when it comes to like education, because I'm going to tell you right now, I don't care how good of an accountant you are, if the people that are using the data are not educated, they're still going to screw it up. So to me, it starts with the ground floor of education first. Any other questions?